Therapeutic Effect of Psilocybin in Addiction, a Systematic Review. Part 2. This is published online in Frontiers in Psychiatry, February 9th, 2023, National Library of Medicine, National Institute of Health. Discussion. In this systematic review, 4 clinical trials with 151 patients assessing the efficacy of psilocybin and SUD were included, of which 3 clinical trials were in patients with alcohol use disorder, and 1 clinical trial was in patients with tobacco use disorder. One of the trials in patients with alcohol use disorder was a double-blind, placebo-controlled RCT, and the other 3 trials were single-arm pilot studies with a substantial risk of bias. All 4 clinical trials, which combined psilocybin with some form of psychotherapy, provided evidence of a significant beneficial effect of psilocybin-assisted therapy in patients with either alcohol or tobacco use disorder. These encouraging results have resulted in several double-blind, placebo-controlled RCTs currently ongoing in alcohol, tobacco, cocaine, opioid, and methamphetamine use disorders. Notable is the lack of trials evaluating the efficacy of psilocybin in patients with cannabis use disorder, despite the high prevalence and the lack of any approved medication for this condition. Fuentes and others showed in their systematic review that 8 eligible RCTs evaluating the efficacy of LSD in patients with alcohol use disorder and 1 eligible RCT in patients with opioid use disorders were conducted in the 1950s, 1960s, and 1970s. Krebs and Johansson identified 33 clinical trials, of which only 6 met modern-day criteria of randomization, blinding, and outcome assessment. This is in stark contrast with the number of clinical trials evaluating the efficacy of psilocybin in patients with SUD before the 1980s, which was only 1, and was contrary to our expectations. 1 trial evaluating psilocybin in patients with alcohol use disorder, conducted in the 1960s, was excluded from this systematic review. It did not include an outcome assessing severity of substance use or abstinence, but only evaluated treatment-related adverse effects. 3 trials included in the systematic review were conducted in the 21st century, in the era after the Controlled Substances Act was signed in 1970. While no trial has been conducted in the past 4 decades evaluating the efficacy of LSD in SUD, although it has been claimed that 2,000 publications have been published evaluating psychedelics in conditions such as SUD, it seems that the majority used LSD as intervention, not psilocybin. Both LSD and psilocybin primarily act via stimulation of the 5-HT2A receptors, but LSD exhibits additional affinity for the dopaminergic and adrenergic receptors. The acute effects of LSD were directly compared to psilocybin in a double-blind, placebo-controlled RCT in healthy volunteers. The 2 psychedelics showed qualitatively and quantitatively very similar subjective effects, and differences in effect are dose-dependent rather than compound-dependent. The onset of effects is significantly earlier, and the duration is substantially longer in LSD compared to psilocybin. A dose of 30 milligrams psilocybin, which is comparable to the dosages used by Bragenschutz and Johnson and others, was found similar to the 100 and 100 units of LSD. However, in the meta-analysis by Krebs and Johansson, which showed a beneficial effect of LSD on alcohol use disorders, 83% of included trials used a single fixed dose of 45 greater than 450 UGs LSD with a maximum of 800. It is unclear whether higher or multiple dosages translate to a more favorable effect than lower or single dosages of psilocybin or LSD. In addition, all the included studies in this systematic review adjusted psilocybin dose to body weight, although there is no clear benefit for this adjustment, and fixed dosing is more practical in clinical trials. Proposed working mechanisms of psychedelics, including psilocybin, for improving psychiatric symptoms such as depression and SUD are both biological. Example, by inducing brain neuroplasticity through elevating brain-derived neurotrophic factor levels, which are diminished in psychiatric conditions, and psychological. Example, the degree to which a patient has a mystical type experience during the psilocybin session seems an important mediator for the enduring effect of the psilocybin. The later proposed working mechanism seems especially important in SUD, as a mystical type experience seems to induce behavioral change in a patient with SUD. This working mechanism would also explain why psychedelics seem effective in different SUDs, as opposed to the currently approved pharmacological treatments for SUD, which have a different working mechanism and are in most cases only effective in a specific SUD. Example, disulfiram in alcohol use disorder. In the design of clinical trials with psilocybin treatment, several important issues need to be taken into account, including an adequate control group, randomization, blinding, and generalization of the results. Regulatory agencies even recognize single-arm trials with external historical controls to assess promising treatments for specific indications. However, 3 trials in this systematic review were non-randomized, had no adequate control group, and were therefore prone to bias. Preferably, future trials are double-blinded, placebo-controlled RCTs to account for the potential placebo effect. Most tobacco use disorder patients had a past use of psychedelics, which could have influenced the expectancy of these patients regarding the efficacy of psilocybin, and thus an effect on the results. Pre-treatment positive expectations about psychedelic microdosing predicted improvements in psychiatric symptoms. A meta-analysis by Wilkinson and others evaluating the efficacy of ketamine for major depressive disorders or bipolar disorders showed a dramatic reduction in effect size when comparing the impact of an inactive saline to the active placebo. Despite comparing psilocybin to an active placebo, Borgenschutz and others still observed a medium effect size for the efficacy of psilocybin. However, even in a double-blind, placebo-controlled RCT, this problem with expectancy effects, a key contributor to the placebo response, is not easily accounted for. Given greater than 90% of the patients and study therapists correctly guessed treatment assignment to either psilocybin and or the active placebo diphenhydramine. Maintaining successful masking remains a major challenge in psychedelic clinical trials, for which there is not yet an adequate solution. Another challenging problem is the generalization of the results. Johnson and others screened individuals. Only 5% of the patients were eventually included. Borgenschutz screened 70 individuals and only 14% eventually included them. They then screened 569 individuals and only 17% were eventually randomized. From a safety point of view, strict in- and exclusion criteria make sense. Still, a risk is that external validity is relatively low and the diminished effects will be observed with psilocybin in a therapeutic setting. co-administration of an extensive psychological treatment, motivational enhancement therapy, and cognitive behavioral therapy during the clinical trials makes interpretation of the treatment effect of psilocybin on alcohol and tobacco use disorder even more difficult. Ideally, an RCT would compare 4 different treatment arms, as in the RCT by Grabsky and others, evaluating the efficacy of adjunctive ketamine in patients with alcohol use disorder to separate the different treatment effects. In this double-blind, placebo-controlled RCT, the 4 treatment arms were ketamine plus psychotherapy, then placebo plus psychotherapy, 3 ketamine and alcohol education, therapy control, and 4 placebo plus alcohol education. The greatest reduction in alcohol use was seen in the ketamine plus psychotherapy group versus placebo plus alcohol education. It seems that the eventual treatment strategy will likely consist of psilocybin combined with psychotherapy, given the latter seems to be needed to derive meaning from the psilocybin sessions and to incorporate insights from the psilocybin sessions into daily life and change current substance use behavior. However, alternative hypotheses assume more direct pharmacological working mechanisms of psychedelics, and thus microdosing would be a potential treatment eliminating the need for the psychedelic experience. However, so far results with psychedelic microdosing are less promising. Currently, greater than 10 clinical trials are registered evaluating the efficacy of psilocybin in SUD, and most are in the alcohol use disorder. Other patient populations include tobacco, cocaine, opioids, and methamphetamine use disorder. Conducting clinical trials in alcohol and tobacco use disorder can be understood from their high prevalence worldwide. It's less clear why no clinical trials in cannabis use disorder are currently conducted, as it is the most common drug use disorder worldwide, especially among youth. Other interesting patient populations to study the efficacy of psilocybin would be benzodiazepines or hypnotics use disorder, and gambling disorder, for which there is a pressing need for effective treatments. Almost all registered trials have a control group and are randomized. The risk of confounding, which was serious to critical in the included non-randomized studies in the systematic review, is minimized. The registered RCT by Johnson is of special interest, evaluating the efficacy of psilocybin combined with psychotherapy versus an approved pharmacological treatment, example nicotine replacement therapy, combined with psychotherapy. Here, psilocybin will be compared for the first time with an improved active pharmacological treatment in patients with SUD. Maintaining masking in double-blind, placebo-controlled RCTs, evaluating psychedelics is usually unsuccessful, which may result in an increased effect size for the efficacy of psilocybin. It is essential to know how psilocybin compares to approved pharmacological treatments and its effect size in comparative efficacy trials. Given that psychological treatments have high relapse rates in the long term, the limited number of available approved pharmacological interventions for SUD, and the high adverse health and economic consequences of SUDs, alternative treatment options are highly warranted for this population. And psilocybin has shown promising first results in SUD treatment that should be replicated and established in larger trials. Questions whether psychotherapy is a necessary treatment component for psilocybin to be effective, and if so, what form of psychotherapy is indicated, and whether higher and/or multiple dosages translate to the more favorable effect compared to lower and/or single dosages of psilocybin are not addressed in the currently registered clinical trials. The results of ongoing and future studies assessing the efficacy of psychedelics in SUD will reveal their true potential. Conclusion. In this systematic review, we identified only one double-blind placebo-controlled RCT and 3 small clinical trials, of which 3 were conducted in the 21st century assessing the efficacy of psilocybin in patients with alcohol and tobacco use disorder. All 4 studies combined psilocybin with some form of psychotherapy and showed a beneficial effect of psilocybin-assisted therapy on SUD, but the risk of bias ranged from some concerns to critical. Future double-blind placebo-controlled RCTs in patients with SUD need to evaluate whether psilocybin-assisted therapy is effective in this population.